All right, the next topic from hemodynamic disorders, followed by thrombosis, is embolism. Embolism is a state of having embolus in the circulation. Embolus means an intravascular solid, liquid, or gaseous mass which is free in the circulation, causing occlusion to the vasculature. So, embolus, in contrary to thrombus, it can exist in any state. Thrombus is always solid, but embolus can be solid, liquid, or gas. And embolus is free in the circulation, but thrombus is always have an attachment to the underlying vascular wall. And we have got different types of embolism: thromboembolism, fat embolism, amniotic fluid embolism, and air embolism. Among all these, thromboembolism is the most common type. So that indicates that in almost all cases or most of the cases, the embolus is nothing but a detached thrombus. And thromboembolism can be of either systemic or pulmonary in nature. So systemic thromboembolism, so where we see emboli occluding the arterial circulation. So most commonly they are seen arising from the cardiac chambers. So as they are formed in the cardiac chambers, those thrombi are known as mural thrombi. So once they get detached from their attachment to the underlying surface, they become emboli and they come into the circulation. So the most common cause for these intracardiac mural thrombi is infarction involving the left ventricular wall. So like myocardial infarction. And once they enter the circulation, so usually they pass down to the lower extremities. So that's the most common site where they get enlarged. And along with the lower extremities, there are other sites like brain and kidneys where they do get enlarged. And whenever an embolus is causing obstruction to the circulation, so obviously because of cutoff of the blood supply, so the target tissues they suffer from ischemia, leading to development of infarction. And then pulmonary thromboembolism, which is the most common type of thromboembolism. And pulmonary thromboembolism usually takes its origin from the deep veins of lower limb. So where you call it as deep vein thrombosis. So those emboli which are actually arising from deep veins of lower limb are nothing but thrombi which got detached from their underlying attachment. So once they enter into the circulation, so they may get lodged at different sites like main pulmonary artery, bifurcation of pulmonary artery, or even smaller branching arteries. And in most of the cases, pulmonary thromboembolism is asymptomatic. Patient doesn't complain of any manifestations. And in some cases, because of obstruction of the end arterioles, so that may lead to development of hemorrhage or infarction. So these small end arterioles, so they may undergo rupture leading to hemorrhage, or because of their occlusion, so the target tissues suffer from ischemia leading to infarction. And very rarely, because of obstruction of 60% or more than that pulmonary circulation being affected, so there may be sudden death of the individual or right heart failure. And then the second most common type of embolism is fat embolism. So fat embolism is usually seen in association with fractures of long bones like femur, and rarely it can be even seen in association with soft tissue trauma or burns. So whenever there is fractures involving long bones, so the bone marrow fat may have access to the circulation through the ruptured vasculature, damaged vasculature, and once entering into the circulation, so there will be release of free fatty acids, and these free fatty acids may cause damage to the endothelial lining of the vasculature. So there may be mechanical obstruction by the fat globules, or there may be endothelial damage by the free fatty acids. And usually followed by 1 to 3 days after the injury, The patient will be seen with sudden onset of tachypnea, dyspnea, and tachycardia. So there will be increase in respiratory rate and difficulty in breathing and also increased heart rate. So there is a syndrome with which patient will be seen. So constellation features are anemia, thrombocytopenia, pulmonary insufficiency along with neurological symptoms. So this syndrome is known as fat embolism syndrome. So as there is involvement of RBCs, platelets and all in the formation of thrombus, so there will be anemia and thrombocytopenia, and because of occlusion of the pulmonary vasculature and cerebral vasculature, so patient will be having pulmonary insufficiency and also neurological manifestations. And this can be demonstrated by the presence of fat globules in pulmonary vasculature. So this picture shows within a blood vessel, so we are seeing adipose tissue along with bone marrow elements. So this confirms the diagnosis of fat embolism. And then moving on to amniotic fluid embolism, where the embolus is nothing but amniotic fluid, so which is very rare nowadays. So it usually occurs as a complication of labor and also during immediate postpartum period. So whenever there is a tear in the placental membrane, so that causes release of amniotic fluid or fetal tissue, and this may have access to the maternal vasculature, and once amniotic fluid enters the maternal vasculature, so amniotic fluid is having such substances which cause activation of the clotting cascade. So there will be diffuse activation of clotting cascade leading to development of thrombi in a diffuse pattern within the maternal vasculature. So because of obstruction to the vasculature, so there are various manifestations the mother suffer from. So there is dyspnea, cyanosis, seizures, or even she may go into coma. And diagnosis is by demonstration of the fetal content like squamous cells, that is skin, or lanugo hair, fat, or mucins within the maternal pulmonary circulation. And this picture shows where the maternal vasculature is showing fetal squamous cells, so within the blood vessels. So this confirms the diagnosis of amniotic fluid embolism. And then air embolism. So air embolism, which is rare nowadays. So the causes are obstetric or laparoscopy procedures, and sometimes because of chest wall injury, which is usually penetrating, or decompression sickness. So decompression sickness is very important. So which is seen in association with deep sea diving or underwater construction workers. So what happens whenever the deep sea divers go deep into the sea from the surface, because of sudden changes in the atmospheric pressure, so the nitrogen gas comes out within the form of emboli when they come back to the surface, and these nitrogen gas bubbles which form the emboli, so they cause obstruction to the vasculature in and around the joints and also pulmonary vasculature. So the nitrogen gas which gets dissolved while going deep into the sea, but when they come back to the surface in a short period because of rapid ascent, now this gas which is actually dissolved in state, it comes out in the form of bubbles causing obstruction to the vasculature. And this leads to two different manifestations, bends and chokes. So bends is actually a painful musculoskeletal condition, and chokes where patient suffers from respiratory distress because of involvement of pulmonary vasculature. And then the second form of air embolism is Kazan disease, which is actually a chronic form of decompression sickness. So Kazan disease involves presence of gas emboli within the skeletal system leading to ischemic necrosis of bones. So the most common bones which get affected are head of femur, tibia, and humerus. So there are two different terms which are important when it comes to the viva. Alright, so moving on to the next topic. So infarction. So we have got three different terms: ischemia, infarction and infarct. So ischemia conventionally means cutoff of arterial blood supply. So whenever there is no arterial blood supply, that leads to development of necrosis, which is coagulative in nature. So ischemic necrosis, and ischemic necrosis results in formation of dead tissue. So the formed dead tissue is known as infarct, and the whole phenomena ischemia leading to infarct formation is known as infarction. So coming to the etiology, so the most common cause is arterial thromboembolic events. So in almost all cases. So very rarely there are other causes which can lead to infarction like vasospasm, atherosclerosis, and compression of the vasculature. And then we have got different types of infarcts. So based upon the color, it can be a red infarct or white infarct. And based upon the presence or absence of infection, so it can be a septic infarct or it can be a bland infarct. And coming to the morphology, so whatever type of infarct it is, usually they are wedge shaped. So at the site of apex, you will find an occluded blood vessel and base usually towards the periphery of the organ. And microscopy, so everywhere ischemia leads to coagulative necrosis except in brain. So within the brain or spinal cord, you will come across liquefactive necrosis, and necrosis is followed by reparative mechanisms like fibrosis. So this is how we differentiate white infarcts from red infarcts. So white are also known as anemic infarcts, red are also known as hemorrhagic infarcts. So white infarcts, they are usually seen in association with arterial occlusions. Red infarcts are seen in association with venous occlusions, like in case of testis, like where there is torsion of testis. And white infarcts, they are usually seen in association with solid organs like kidney, spleen, and heart. And red infarcts, they are usually seen in association with loose tissues like lung. And endarterial circulation, where there is no scope for collaterals, they are always seen in association with white infarcts. And those organs with dual circulation, like lung or liver, they are usually seen in association with red infarcts. So the first picture shows the spleen showing various infarcts, so which are actually white or anemic in nature, and you can easily see them in wedge shape. And in the second picture, so the lung is showing a red infarct, so because lung is a loose organ and also having dual blood supply, so that's why what you are seeing a red or hemorrhagic infarct. And next, there are various factors which determine the development of infarct. So firstly, nature of the vascular supply. So whether the organ is seen with endarterial blood supply or dual blood supply. And then rate of development of occlusions. So slowly developing occlusions, so they take some time, so less likely to infarct. But rapidly developing occlusions, so usually they tend to develop infarcts. And coming to the vulnerability to hypoxia, as you might be all knowing, so neurons are very rarely withstand more than 3 to 4 minutes of hypoxia. So within 3 to 4 minutes of hypoxia, neurons will die. And then comes myocardial cells. They can withstand hypoxia for about 20 to 30 minutes. Later on, myocardial cells even they die.